On the endocrinology ward, two people came in with similar symptoms. One of them is 45-year-old Samantha, who complains of gaining a lot of weight lately. Samantha also suffers from severe asthma, for which she's taking oral glucocorticoids. She's also had many viral and bacterial infections of late. On a clinical examination, there's truncal obesity, a large hump behind her neck, and striae on her abdomen. Her arterial pressure was elevated, and she also had hyperglycemia. The other person is 38-year-old Dan, who's also obese and has an abnormally round face. He has arterial hypertension and hyperglycemia. Unlike Samantha, Dan is not taking any medications. A 24-hour urine-free cortisol was done in both individuals, and their levels were high. Further investigations were done, including ACTH levels. Now, both individuals suffer from an endocrine disorder that involve high levels of cortisol. This is generally called Cushing syndrome. Now, if Cushing syndrome results from a pituitary adenoma making excess ACTH, it's called Cushing disease. Normally, the hypothalamus secretes corticotropin-releasing hormone, known as CRH, which stimulates the pituitary gland to secrete adrenocorticotropic hormone, known as ACTH. ACTH travels to the adrenal glands, where it targets cells in the adrenal cortex. The adrenal cortex is the outer part of the adrenal gland and is subdivided into three layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. Zona fasciculata is the middle zone and also the widest, and ACTH specifically stimulates cells in this zone to secrete cortisol. This is a class of steroids, or lipid-soluble hormones, called glucocorticoids. Glucocorticoids are not soluble in water, so most cortisol in the blood is bound to a special carrier protein, and only about 5% is unbound or free. In fact, only this small fraction of free cortisol is biologically active, and its levels are carefully controlled. Excess free cortisol is filtered in kidneys and dumped into the urine. Free cortisol in the blood is involved in a number of things, and it's part of the circadian rhythm. Cortisol levels peak in the morning, when the body knows we need to get up and go, and then drop in the evening, when we're preparing for sleep. In times of stress, cortisol increases gluconeogenesis, proteolysis, and lipolysis. Cortisol also helps maintain blood pressure by increasing the sensitivity of peripheral blood vessels to catecholamines, which further cause vasoconstriction. Cortisol helps to dampen the inflammatory and immune response by reducing the production and release of inflammatory mediators, as well as inhibiting the proliferation of T lymphocytes. Finally, cortisol receptors are present in the brain, where their full effect is still actually unclear but might influence things like mood and memory. For all this to work properly, though, the levels of free cortisol have to stay within the normal range. To do that, the body uses negative feedback, which means that high levels of cortisol tell the hypothalamus and pituitary gland to decrease their secretion of CRH and ACTH respectively. Less CRH also tells the pituitary to make less ACTH, so the pituitary ends up having two reasons not to make ACTH. With less ACTH floating around, the zona fasciculata gets less stimulation to make cortisol, and eventually, cortisol levels go back down to the normal range again. Okay, now Cushing syndrome can be caused by exogenous cortisol used as medications or endogenous cortisol, meaning that the excess cortisol is made by the body. A very high-yield fact is that the majority of cases of Cushing syndrome occur in individuals using exogenous cortisol, like prednisone, over a long period of time, often as a treatment for autoimmune and inflammatory conditions, like rheumatoid arthritis or poorly controlled asthma. They have structures similar to endogenous cortisol and mimic its actions in various tissues. In fact, exogenous cortisol can also cause negative feedback on the hypothalamus and the pituitary gland, leading to a decrease in CRH and ACTH, which in turn shuts down cortisol production from the zona fasciculata. Over time, this lack of stimulation can cause zona fasciculata of both adrenal glands to physically shrink or become atrophic. Even though this results in less endogenous cortisol production, it still doesn't quite compensate for the huge levels of exogenous cortisol, and that causes Cushing syndrome to develop. Now, if the medication is stopped abruptly, the atrophied adrenal glands can't produce enough cortisol, so we get adrenal insufficiency. If the cortisol level is low enough, it might trigger an adrenal crisis. This is a life-threatening condition with symptoms like fever, hypotension, severe abdominal pain with vomiting and diarrhea, confusion, psychosis, and coma. In addition to taking exogenous steroid medications, Cushing syndrome can also result from increased levels of endogenous cortisol. The most common cause is Cushing disease, where the pituitary releases too much ACTH. For your exams, remember the leading cause is a pituitary adenoma, which is a benign tumor of the pituitary gland. The exact reason for the development of this sort of benign tumor isn't known, and the pituitary adenoma simply grows in size and secretes excess ACTH. This causes the zona fasciculata of both adrenal glands to undergo hyperplasia and secrete excess cortisol. Apart from pituitary adenomas, there are ectopic sources of ACTH, such as paraneoplastic syndromes. The high-yield ones to remember are small cell lung cancer and bronchial carcinoids. In these cases, the excess ACTH is coming from somewhere other than the pituitary, so these cases are not considered Cushing disease. Another common cause of endogenous Cushing syndrome is tumors of the adrenal glands that make excess cortisol, like adrenal adenomas, which are benign tumors, and adrenal carcinomas, which are malignant tumors. In both adrenal adenomas and carcinomas, the cells of the zona fasciculata within the adrenal cortex start dividing abnormally and secrete excess cortisol. As before, the excess cortisol provides negative feedback to the hypothalamus and pituitary gland, suppressing CRH and ACTH production. This doesn't have any effect on zona fasciculata of the involved adrenal gland, since the neoplastic cells are autonomous, meaning that they grow independently from ACTH. However, the zona fasciculata of the uninvolved adrenal gland shrinks and atrophies. This could be a clue to help you narrow down the cause to the adrenal gland. The net result, though, is abnormally high levels of cortisol, and that causes Cushing syndrome. Regardless of the cause, the symptoms of Cushing syndrome are directly related to the effects of excess cortisol and other glucocorticoids on its various target tissues. Since cortisol levels are elevated chronically, its effects will be exaggerated. Excess cortisol leads to severe muscle and skin breakdown, which are major sources of protein in the body. This leads to muscle wasting and thin extremities, skin thinning, easy bruising, and abdominal striae or lines. The bones are also broken down for calcium, so fractures can occur due to osteoporosis. Next, there's elevated blood glucose level due to increased gluconeogenesis in the liver. As a result, insulin level goes up, and eventually insulin resistance develops. Cortisol also increases appetite, which can lead to weight gain. This can manifest as truncal obesity, but there's also fat redistribution to the cheeks, resulting in a round, moon-shaped face, and to the back of the neck, causing buffalo hump. Cushing syndrome can also lead to arterial hypertension. That's because cortisol can amplify the effect of catecholamines on blood vessels. Second, cortisol is a weak agonist for mineralocorticoid receptors. So, it can act like a weaker version of aldosterone and increase blood pressure by causing the kidneys to retain more fluid and sodium. Remember for your exam that this is called pseudohyperaldosteronism. High levels of cortisol also inhibit the secretion of gonadotropin-releasing hormone from the hypothalamus, which messes up normal ovarian and testicular function. In females, this leads to amenorrhea. Now, in cases with high levels of ACTH, such as Cushing disease, ACTH can also stimulate the production of androgen hormones, leading to hirsutism in females. Excess cortisol also dampens the inflammatory and immune response, making individuals develop a form of immunosuppression, making them more susceptible to infections. Finally, high levels of cortisol seem to impair normal brain function, but the exact mechanism is unclear. Diagnosis of Cushing syndrome is a simple algorithm that's very high yield. It's initially based on measuring the free cortisol in a 24-hour urine sample to confirm cortisol levels are high. Alternatively, blood or saliva tests at midnight can help check if there's a normal daily rise and fall of cortisol levels. Another option is also the dexamethasone suppression test, which is when a person is given a low dose of dexamethasone, which is an exogenous steroid that suppresses ACTH production in the pituitary gland. Normally, that should cause a decrease in serum cortisol levels. But if Cushing syndrome is caused by endogenous cortisol production, then the serum cortisol level should remain unchanged. If that test is positive, the next step is to determine the exact cause of endogenous cortisol production, and ACTH plasma levels can be checked. Low ACTH levels can be seen in adrenal adenomas, adrenal carcinomas, and exogenous glucocorticoids, whereas high ACTH levels can be seen in Cushing disease and ectopic ACTH production. If the ACTH level is high, the next step is to give an injection of a high dose of dexamethasone, and this is called a high-dose dexamethasone suppression test. If there's no suppression, and the ACTH level remains the same, it means there's an ectopic site of ACTH productions, in which case a CT of the chest, abdomen, and pelvis can be done in order to find the source. If levels of ACTH fall after the high-dose dexamethasone test, then this means it's Cushing disease, in which case an MRI of the pituitary is done to confirm. An alternative to the high-dose dexamethasone suppression test is the CRH stimulation test, where an individual is given synthetic CRH. Now, if there's no rise in ACTH and cortisol after the test, then this means ACTH secretion is ectopic. And just as before, a CT scan of the chest, abdomen, and pelvis are done. If there's a rise in ACTH and cortisol, then this means the pituitary responds to CRH, and we're talking about Cushing disease, in which case an MRI of the pituitary is done. Alright, as a quick recap, Cushing syndrome is a set of symptoms caused by high levels of glucocorticoids. The most common source is an exogenous cortisol like prednisone, but it could also be caused by endogenous cortisol production within the body. Steroid medication can cause negative feedback in the hypothalamus and the pituitary glands, leading to a decrease in CRH and ACTH, which in turn shuts down cortisol production. Over time, both adrenal glands can become atrophic. In case of endogenous cortisol, the most common cause is excess ACTH that usually happens due to a pituitary adenoma, and this is referred to as Cushing disease. The excess ACTH caused both adrenal glands to undergo hyperplasia. Apart from pituitary adenomas, there are ectopic sources of ACTH, like paraneoplastic syndromes associated with small cell lung cancer or bronchial carcinoids. Another common cause of endogenous Cushing syndrome is tumors of the adrenal glands that make excess cortisol, like adrenal adenomas or adrenal carcinomas, and in this case, CRH and ACTH production are suppressed and the normal adrenal gland atrophies. Symptoms of Cushing syndrome include arterial hypertension, weight gain, and truncal obesity, moon face, buffalo hump, thinning and striae on the skin, hirsutism, osteoporosis, hyperglycemia, amenorrhea, and immunosuppression. Diagnosis of Cushing syndrome is based on a high 24-hour urine-free cortisol test, a high late-night salivary test, or inadequate suppression on the dexamethasone suppression test. Next to identifying the cause, ACTH levels are taken. Low ACTH levels can be seen in adrenal adenomas, adrenal carcinomas, and exogenous glucocorticoids, whereas high ACTH levels can be seen in Cushing disease and ectopic ACTH production. If the ACTH level is high, the next step to do is a high-dose dexamethasone suppression test. If there's no suppression, then this means there's an ectopic site of ACTH productions, in which case a CT of the chest, abdomen, and pelvis can be done in order to find the primary tumor. If levels of ACTH fall after the high-dose dexamethasone test, then this means it's Cushing disease, in which case an MRI of the pituitary is done to confirm. Now back to our cases. Samantha came in with arterial hypertension, truncal obesity, a buffalo hump, striae on the abdomen, and hyperglycemia. All of these are signs and symptoms of Cushing syndrome. The cause is most likely the glucocorticoid she's been taking for her asthma. This decreased her immune response, which is the cause of the repeated viral and bacterial infections. A 24-hour urine-free cortisol was done, and levels were high. Furthermore, ACTH levels were low, meaning that cortisol secretion is independent of ACTH. This confirms the diagnosis of Cushing syndrome caused by exogenous glucocorticoids. Now, Dan came in with similar symptoms as Samantha, but he didn't have a history of glucocorticoid use. Tests showed high levels of urine-free cortisol, but this time, levels of ACTH were high, and high-dose dexamethasone suppression test was done, and this showed adequate suppression of ACTH levels. This means that Dan most likely has a pituitary adenoma, which is responsible for the high levels of cortisol and ACTH. When a pituitary adenoma is the cause of Cushing syndrome, we call this Cushing disease. An MRI of the pituitary will be done to confirm the diagnosis.